We are starting our newborn assessment lecture, normal newborn. One thing as we start with ABGAR scoring, just want to make this over here, okay, and move this to the next slide, okay. Just as we are starting our normal newborn lecture, newborns undergo profound physiologic changes at the moment of birth as they are coming from an intrauterine environment to an extrauterine environment. Within minutes, the newborn has to initiate respirations and adapt to a circulatory system, to extrauterine oxygenation. Within those 24 hours, neurologic, renal, endocrine, GI, metabolic function must be operating competently for life to be sustained. And usually, how well a newborn makes these major adjustments depends on his or her genetic composition, the competency of that recent intrauterine environment, gestational duration, that presence of fetal anomalies, and very important is that care that was received during labor and birth. So that's very important. Newborn health is very important to families. That the 2020 National Health Goals related to newborn health have been stated in your book as well on page 426 on that box that says 18.1. And as you can see, nurses do play a major role in achieving these goals because, of course, we are unique into giving these newborns care and also newborn instructions to the parents. So as a labor and delivery nurse, as a nurse that works in transition nurse, meaning that you are getting this baby as soon as this baby is born, whether it's in the C-section room, in the operating room, or whether it's in the labor room, you are receiving this newborn, you're putting this newborn under the radiant warmer, and you're doing your initial head to toe assessment. You're getting your ABGARs, you're doing your assessment initially. And then again, after mama gets into labor room and then into postpartum room, you are doing this head to toe and you are giving instructions to the mom before this baby goes home. So we are unique and we are essential in the care of this newborn. We're going to start with ADGAR scorings, okay? And there is a number, I just want to let you know where ABGAR scores came from. We'll do the newborn care, the delivery room, and then we'll go into ABGAR scores. So immediately, we want to dry the infant under that radiant warmer. We suction the mouth, the nose with that bulb syringe. Remember in the labor and delivery lecture, when this baby is out, okay, we immediately dry the baby, put the baby under the radiant warmer. We suction the mouth and the nose with a bulb syringe, and obviously we're going to assess that airway status, okay, looking at those 5 symptoms of respiratory distress, so retractions, tachypnea, dusky color, expiratory grunt, and nasal flaring. And again, going back to what we were talking before, that ABGAR score at 1 minute and 5 minutes. Now, ABGAR scoring, what is all this about? Well, there's assessments. These are assessments for well-being, okay? There is a number of them that we call traditional standardized assessments, as well as a history and physical exam that are done at birth to evaluate a newborn for maturity and also for general well-being. ABGARs are done at 1 minute and at 5 minutes after birth, and they're absorbed, they are observed, and they're rated according to an ABGAR score, okay? It's an assessment scale used as a standard for newborn evaluation, and it's been going around since the 1950s. So what we are doing is we're evaluating infants' transition to extrauterine life. Okay, so take the heart rate, for example, and it's rated. So it's either 0, 1, or a 2. Okay, and when everybody goes, those that have gone have listened to this already, and those that will be going Thursday and those that will be going the following week to your OB Med-Surg Skills Day, we will be going through this again. So you will be getting this again, and you'll hear the explanation again. It gets a rating, so it'll be 0, hopefully never 0, to 2. A perfect ABGAR score is really 9-9 and not really a 10-10, because they're always going to lose that 1 point for color. The body's going to be pink, the extremities are going to be blue. Okay, a little short time after they're born, it'll start to change, but immediately as they're born, that umbilical cord is cut. It will perfuse the body, the torso will perfuse first, and then it goes out to the extremities. And it takes a little longer than 5 minutes for their hands and their feet to be pink. So number 1 is actually considered normal here in the color, so they're going to lose at 1 point. So the perfect scoring will be 9-9. So heart rate, as we know, immediately after birth, their fetal heart rate is still going to be 110 to 160. And as they settle, a few minutes within that hour, as they settle, as we're already doing all the head to toe, we're doing the vitamin K, we're doing their hepatitis B, we're doing their injections, which is 30 minutes to an hour. As they settle and they fall asleep, then they start to change their heart rate, more like in the 120s, 140s. You will see that. Okay, it does go as lower to almost 100, and then it tends to go, as high as the 180s if they're crying again. That's why in your ABGARs, the heart rate, anything over 100 is a good reading. It's a 2. Okay. Respiratory effort should be 30 to 60 respirations per minute. So a good cry, we want to make sure, okay, a good cry is a 2. And if they also have a respiratory rate, this is how we evaluate. If it's absent, hopefully not, then it's a 0. Okay, if it's between 30 and 60, it's a 2. Okay, now if they're breathing somehow, if it's slow, but they're still breathing, okay, and they're maybe a 20 or a 15, they will get a 1. Okay, so respiratory effort, if you go by the normal of the heart rate, you will be able to do the 2. If you do 30 to 60, you'll be able to, if it's slow, then you'll be able to do a 1. If it's perfect and it's between 30 and 60, you'll be able to do a 2. If they're not, then it's a 0. Muscle tone, hopefully they have active motion. There's some flexion is a 1, but they're active, they're moving all their extremities. That's what you want. And then reflex irritability, they're stimulated through touch. So if we're touching them, hopefully they're not going to like it, and they're going to be crying, and they're going to be, like I always tell them, little fighters are trying to fight you. Okay, that's a reflex irritability. So crying is a good thing. The color, again, they're going to lose a point for color, so their bodies are going to be pink, their extremities are going to be blue. Okay, it is common to see some mottling several hours after birth on these on the newborns. Okay, and they do what the hands and the feet, they have this acrocyanosis is what we call it, and that's the result of a deficient amount of blood circulating to the extremities. So their hands, their feet, sometimes around their mouth, it's going to be blue, and that's your acrocyanosis. acrocyanosis. Okay, acrocyanosis. Again, this guide is used if we need to further resuscitate this newborn. Okay, if we need resuscitation efforts on this newborn, if we need to call the NICU, if this newborn needs a little bit of CPAP, a little bit of oxygen, a little bit of suctioning, the ABGARDs will say a lot between 1 minute and 5 minutes. Anything less than 7. So vigorous, if it's more than 7, this is great. But if it's less, if the numbers are less than 7, then of course it's not vigorous anymore, and this newborn needs a little bit of help. Okay. There are some routine admission orders, and we're going to go through these as we go through through the newborn assessment lecture. Vital signs, measurements, their medications, a dextro stick, PRN, labs that are PRN, and then there's a newborn metabolic screening, okay? And this is called inborn errors of metabolism. We will talk about this at the end of our high-risk newborn lecture, okay? We have a whole section on inborn errors of metabolism, so stay tuned. A slide here for you on newborn sleep and how newborns sleep. They go into this deep, quiet sleep, then they go into activity REM, and then they go into this quiet alert, where they're awake and they're involved with the surroundings, and this is when they're awake and crying. Then their greatest source of heat loss at birth, okay? So they're trying to do temperature adaptation, okay? They're trying to regulate their temps. So evaporation, okay, we're going to take, this is your picture here, and you have your slide, but we have the picture on here. Evaporation, heat is lost when the fluids from the body turn to vapor. Okay, so you have here evaporation right here. Okay, that's why we have to dry the baby as soon as a baby is born. We can't leave a baby wet. We've got to dry this baby. If we bathe the baby, of course, with normal temp, if we bathe this baby, because if the baby is very cold, we're not going to bathe this baby right away. So if we bathe this baby, we have to make sure the baby is always, always dry, okay? Because they can lose heat, okay? Body turns to vapor, they can lose heat by evaporation. Then we have conduction right over here, right? This little baby here, okay? Then we have conduction. Conduction, heat is transferred from a warmer object to a cooler object, okay? Here's conduction. Heat is transferred from a warmer object to a cooler object by direct contact, okay? And you could see down here too, conduction, heat loss due to direct contact with a colder surface, okay? So it's down here what I'm talking about, okay? So what does this mean? Placed, okay, let's say this baby, if this baby is placed naked on a cooler surface, like on a scale, we put this baby on a scale, we don't want to do that. We want to put at least a blanket over the surface because the scales are pretty cold. Some of them are metal, some of them are plastic, and they're cold. So we want to put a blanket over the scale and then put them on, okay? So they don't lose heat through conduction. And then we have radiation, just like it says here, heat loss via infrared heat waves due to the body's metabolism. So radiation, another way of explaining this, is heat is transferred from a warm object to a cooler object by indirect contact, okay? Heat is transferred from a warm object to a cooler object by indirect contact. So what does that mean? Keep the baby covered on a cold isolette, okay? So they don't lose heat through radiation. And then we have convection, okay? Heat loss due to air movement, okay? Heat is lost from the warm body surface to cooler air currents. Warm body surface through cooler air currents. So cold rooms, okay, cold rooms, if they're transported through the hall, keep away from windows and fans. And that's the most important, is keep the babies away from windows and fans and keep the babies covered so that they do not lose body heat. Okay, they don't lose heat loss through convection. Okay. Then we have newborn measurements. Okay. Let's go back here. Newborn measurements. So their weight is about 5.8 pounds to about 8.13 pounds. That's the average. 5.8 pounds to about 8.13 pounds. Okay, their length is about 19 to 21 inches in the average of the newborn. Head circumference, as you could see here, that's being measured, is 33 to 35 centimeters. Chest circumference, as you see it measured here, is about 30.5 to 33 centimeters. Okay, the weight again is 5.8 pounds to 8.13 pounds. The length is about 19 to 21 inches. You've got the head circumference, which is about 33 to 35 centimeters, and then the chest circumference, which is about 30.5 to 33 centimeters. And this is how you measure, okay? You will put a line. There's a piece of white paper on here, usually under the radiant warmer. You put a line over here, you stretch, okay, their little heads over here. You put a little line and then go ahead and stretch the tape measure, stretch out their leg, okay, and then put another little mark over here. And then you're going to measure, okay, from one mark to the other, okay? So here's more on newborn assessment. We just went through newborn measurements, newborn assessment. So temperature, normally at birth, they're about 99 degrees, okay, because they have been confined in their mother's warm and supportive uterus, okay? The temperature will fall almost immediately, okay, to a below normal because of heat loss, okay, which is normal, okay? So they start off at 99 and they do fall almost immediately below normal because of their heat loss, okay? Infants have immature temperature regulating mechanisms. So these babies do need to be protected from heat loss at birth. And of course, afterwards as well. Okay, so this is why this is the norm. We want them in the hospital to be more toasty, more in the 98s. That's why 97.9 is an average your book has as well. Hospitals want them more on the 98s. Okay, you can't bathe a baby that is cold. So make sure that we keep our temperature. Apical heart rate, always want to make sure that we can assess an apical heart rate and we listen to an apical heart rate for an entire minute. Okay. A little bit on the heart rate, 110 to 160 is still the normal fetal heart rate. They're going to be immediately after birth. They're obviously going to still have 110 to 160. And then there's a range, after 1 hour, after 1 hour after birth, they can settle down to sleep where their normal then becomes in the 120s to the 140s. And it can get up to 180 if they're crying, okay? That this is right after birth, this is what it's supposed to be, about 110 to 160. Then you have your respirations and you have your blood pressures. Unless there is a cardiac, something circulatory, an issue, a challenge that's circulatory going on with the newborn, they will not, we will not have blood pressures taken. The system is still very immature. So you won't see newborns that we take blood pressures in postpartum. We'll do the temp, we'll do the apical pulse, we'll do the respirations. Unless there is a challenge, we will not do blood pressures. But if they're in the NICU, yes, in the neonatal ICU. And like I told you before, this is the radiant warmer, okay? This is the nurse assessing the apical heart rate, okay? This is the baby being mad because, of course, tactile stimulation, they don't like it. They're used to a warm environment in utero. They are not liking that now we are touching this baby, poking this baby. So yes, they're going to be mad. And this is a beautiful, just how this baby's laying right here with this little hand, okay, towards the baby, this little leg. How this baby contracts a little leg, and of course the left is extended. The left hand is trying to be extended, but we have a little plastic here, and their face is to the left. This is called tonic neck reflex. So stay tuned, tonic neck reflex. You will see this again. They will extend their extremities, upper and lower, when their head is moved to that side. So if it's moved to the left side, their upper extremities and their lower extremities are extended, and then their opposite extremities are contracted. Love this picture. Okay. So we're going to start with our head to toe. So the head, what are we looking for? So in the scalp, we're looking to make sure that there's the size, for shape, for symmetry, for moldings, for bruising. Okay. We've got some pictures. So since you have it on your slide, I'm just going to turn into caput succedaneum and tell you the definition of caput succedaneum. It's a soft tissue edema due to constant pressure. This is the fluid that's absorbed in a few days. And we've got cephalohematoma. These are ruptured blood vessels between the skull bone and the periosteum, and that is the layer right above the skull bone. So that's cephalohematoma. And this usually will resolve in about 2-3 weeks, sometimes a little later, but usually in about 2-3 weeks it will resolve. And you've got the fontanelles. They're supposed to be soft and flat. They're not supposed to be bulging. Okay, soft and flat. If they're bulging, that might give us an indication of intracranial pressure. Okay, they're usually 3 to 4 centimeters long and 2 to 3 centimeters wide. The anterior, which is the one right here that that you see with my cursor, close it by 18 months. The posterior ones, okay, close usually by 8 to 12 weeks, but we really pay attention to the anterior fontanelles. Here's another picture how we're assessing fontanelles as well. The newborn's eyes. Now, tears are not produced until 1 to 3 months, so the drainage that's coming out of their eyes is going to be clear. Okay, their eyes are going to be swollen for several days due to the delivery installation of the prophylactic medication that we are given. Now, we're given it for gonorrhea and chlamydia regardless of mom's gonorrhea and chlamydia status. It's for neonatal infections. Okay, neonatal infections means infections that they can acquire as a newborn as they go through the birth canal. So to protect them from any infections in their eyeballs, we're giving them this prophylactic antibiotic. Okay. So we're looking at eyes for symmetry, shape, position. The nystagmus is normal, and this is a movement around the iris. Their scleras need to be white. Okay. And they usually will close their eyes in the presence of bright light. Looking at the ears, we want to make sure that the ears, just a picture of the ears, we want to make sure the ears are positioned similar on both sides. We're looking for alignment and we're looking for symmetry. Okay, now this is a big difference. Let's say for a baby that's on Down syndrome, they have low setting ears, okay, abnormal size versus normal size, okay, and normal shape, okay, and how this baby has low setting versus this baby. Now, another thing to check that's normal is the tip of the ear right here, which is the helix, okay, should be at the level of the eye. So if you go like this, it's going to be straight line, okay. This baby has low setting ears, like if we're assessing a baby that's Down syndrome, one of the assessments that we will do is find, and most of them do have low setting ears. Look at this. Look at this arrow. It's thinking that I want to change the page. See how you're going this way instead of a line that's flat. Okay, that's straight, absolutely straight. So look at their low setting versus this one that's completely straight. This one's in a low angle. Okay, so that's important. So the tip of the ear, which is the helix, should be at the level of the eye. Okay, low set ears, like we just talked about in this picture, okay, will tell us about chromosomal abnormalities or renal problems and challenges that this newborn is now encountering. And more, so we could do assessment. One more thing before we leave the ears, the hearing. We respond. So babies, we do indirectly know that they're listening because they respond to the soothing voice by turning their head and their eyes. So if mama is feeding the baby or if she's breastfeeding the baby and you're talking to them, and let's say they're looking away and you're talking to them in their right ear, they usually will turn and kind of look, okay, towards that, turn their head towards you, so they're responding to your soothing voice. So nose, we need to make sure that they're not flaring their nostrils because that's a sign of respiratory distress syndrome. We need to make sure that the parents have a nice bulb syringe so they can suction the nares, because the nares have to be patent at all times. They have to maintain clean and clear nares. We're looking at shape, we're looking at size, we're looking at position on the face, patency, and they're nose breathers. They're obligatory nose breathers for the first 6 weeks. They're obligated to only breathe by their nose. So we need to make sure that their nares are kept clean and clear. We check the mouth with a gloved finger. We want to check their mouth, sucking reflex, okay, and the gag reflex as well. So we're looking at symmetry. We're making sure that they have open equal angles. We're looking bilaterally. And then Epstein pearls. Okay, this is normal. This is the Epstein pearl right over here. Okay, this is normal. These are white cyst clusters about midline of the hard and soft palate. And this is normal. And this resolves spontaneously with sucking. Then there's thrush. Okay, white. It's about oral candidiasis. So these are white plaques. Sometimes they'll get this if mom has a history of vaginal candidiasis, or there's an infection, the nipples and the areola, or there's a previous history of antibiotic therapy that mom took. And how do we treat it? We treat it with nystatin. And how do we know? Sometimes they will call the healthcare provider's office or pediatrician, and they will say, my baby has a white tongue, something's not right. And sometimes we tell them they can bring the baby in, or if they're able to do this at home, they can go ahead and they can hold the baby. They have a little 2x2 at home, or with a little towel, just pull the tongue a little out, and they can get a Q-tip and they could put the Q-tip, on top of the white plaque. If it goes away, it's milk. If it doesn't go away, then obviously is a thrush infection. Okay. And then I wanted to mention, because we are the first eyes that look at this baby once these babies are born, and we will identify a baby that has, bilateral cleft lip and palate. This is abnormal. This baby will go through many different surgeries to correct it. And then, of course, further evaluation, so that this baby can have their surgery. And this, you will learn all of the care after that. You will learn in PEDS in block 4. But then again, we're doing the initial newborn assessment. We're in the labor room. This is a transition RN, and we initially are the eyes of this baby, the eyes and the ears of this baby, because then we're going to take this a step further, and then this baby's going to get evaluated, okay, for chromosomal abnormalities, and also, for the repair later on. So the neck, okay, and the trunk, they're going to be able to open their mouth and move their head side to side. In their range of motion, we need to make sure they have an intact clavicle that we can palpate. Okay, their chest area, make sure that we can listen to an apical pulse for a full minute. Okay. Also, we want to palpate femoral pulses, and these are very important. You should always be able to palpate femoral pulses. Okay. In the video that you saw, and in the video that you will see in Skills Day, the video shows that the RN is also palpating femoral pulses, part of your head to toe assessment. If they're absent, that can suggest a possible coarctation, a narrowing of the aorta, which is not good. Okay, then that would be, abnormal. Make sure pedal pulses and radial pulses and brachial pulses are a little more difficult. You still want to assess them, but they're a little bit more difficult to hear. But femoral pulses, absolutely, for sure. Okay, and obviously your apical pulse for a full minute. And also the capillary refill. Okay, we need to make sure they have good capillary refill. There's pink that's returned, the palm of their hand, return pink in 2 seconds. And how you know the capillary refill is you press against the sole of the foot or the palm of their hand, and then you release, and it turns to pink in 2 seconds. Now, something very, of course, this again, something very interesting with breathing, thinking about the auscultation of the lungs here in an S form, and thinking about that as well. They breathe in regularly, okay? So they usually breathe and they stop. And they stop again because they have something called irregular breathing. They have 10 seconds, okay, and then they stop. So usually what is considered normal is that they have this irregular breathing. They have 10 seconds that they are without breathing, but it's going to be okay if they don't have any color change. They're still pink, they're still going strong. Now, if they stop and they keep going and there's color change and there's a challenge with circulatory, okay? But this baby like this can be really agitated and all of a sudden they stop and they continue on again, okay? With no color change, absolutely. This is what I was saying, that this is a great little fighter right here, a nice little boy fighting the nurse, as the nurses, of course, now they're in this extra uterine environment. They were nice and comfortable in utero, and now we're, of course, stimulating them, putting our hands on them, wanting to listen to their apical heart, and they're so upset. A lot of times you'll see that they're with a little gloved finger, we'll put it in their mouth, they start to suck, and then they calm down a little bit, and then we can actually listen to their apical pulse for an entire minute because it's fast. So the more you do, the more practice you'll get. Okay, so abdomen, we have to rise their abdominal breathers. So not only are there irregular breathers, they're also abdominal breathers. So we look at the rise and fall of their abdomen. Okay, their bowel signs are assessed times 4 quads for a minute each, okay, as they're breathing. Okay, and their umbilical cord has 2 arteries and 1 vein. And usually about 48 hours after they're born, it starts to get dry and crusty, just like right here. It starts to get dry and crusty. Okay. And this is how we're clamping their cord. They're born and we're clamping their cord. Okay. Now, on the male genitalia, we look at the size and the location in a little frog position. Okay, this is a little frog position. Okay, we're looking at their male genitalia. We're looking at their size and the location. Now the length of their little penis, their length when it's not erect is about 2 to 3 centimeters. Okay, the glans is covered by a foreskin at birth, as you could see. Ability to retract the foreskin over the glans. Okay, retracted foreskin. So this is their foreskin. Okay, usually it's about 2 to 3 centimeters. Their testes, okay, you want to retract enough to see the urethral opening. Okay, you want to retract enough, and let's go to the next picture. You want to retract enough to see the urethral opening. Okay, now the testes, over here is another picture, they're palpable in the scrotum. Okay, if they're palpable but they're not movable, or if they're not palpable in the scrotum, then that means that they have undescended testes. So if they're palpable but not movable, or if they're not palpable in the scrotum, that means that they're undescended testes. Okay. The phimosis, again, we'll go back here. The phimosis is the foreskin. There we go. It's the foreskin. And we talk about hypospadias, which you will further talk about the care, the surgery in block 4 is hypospadias and epispadias. And hypospadias, because remember, you are doing your initial newborn assessment. So you are the eyes initially when this baby is born, okay, and doing the inspector of everything. So we are looking at the urethral opening. We want the urethral opening to be in the tip, okay, of the penis. And when it's not, it's called hypospadias. That's when the urethral opening is on the ventral surface of the penis. And then the epispadias is on the dorsal surface of the penis. Okay, and here it is. It's a relatively common abnormality. This is the hypospadias, in which the opening is on the underside rather than at the end of the penis. And obviously they do surgeries for both. Okay, another picture with the circumcision, okay, of these newborns. Make sure I put this up. Okay, circumcision is the surgical removal of the foreskin of the penis. Okay, uncircumcised penis, and then obviously a circumcised penis. What I'm going to point out is in the education that you're going to give to the parents as this baby heals. Okay, of course, we want to make sure that there's urination within 24 hours. Okay, of them being born, and then of course they'll schedule them for being circumcised, and then of course they have to keep on urinating. But as very important to point out as this baby's being circumcised after circumcision is the healing of this newborn is there's a crusty yellow crust that forms around the penis that is normal, and we tell and usually lasts about a few days, maybe can be up to like 5, 6, 7 days. We tell the parents not to clean it, leave it alone. That is part of their healing process, okay? And then you can put Vaseline, okay, petroleum jelly. You can put a little gauze on it. Right now, we're just doing Vaseline so that it doesn't stick to the diaper, Vaseline, and then the diaper is on. We used to do a lot of a gauze and then, of course, the Vaseline. We don't do the gauze pretty much anymore. We just do the petroleum jelly on the penis, and then of course the diaper change. Okay, so on the female, and this is a baby that again does not liking the fact that now we're weighing them, we're checking them, we're looking at them, not liking it. So again, a little fighter, love it. Okay, again, urination within 24 hours. The size and the location of their labia, their clitoris is going to be edematous. There's going to be a hymenal tag that you will be able to see. And then, of course, there's edema, okay, on the little female. Then we've got the anus and the spine. We want to make sure that there's passage of meconium within 24 hours, that we're looking at their spine and we're looking at the spine for any defects. Okay, if we see a little pimple, we're going to stretch it with our fingers to make sure that there's nothing under, that there's no openings, there are no masses, there are no curves. Because we are detecting if there's some neurotube defect, okay, and that's failure of the spinal cord to fuse together. So we have to pull it open to make sure there's no spina bifida present. Okay, those terminologies that you will get in block 4 as well when they talk about neurotube defects. Okay, but that's why we check the spine. If you're right-handed, you can put the baby on your left hand. With the right hand, you can go all the way from cervical all the way down, tracing that there's no curvature on the spine, that it's pretty straight down. And then, of course, if you see any pimples, any little tuft of hair, you can spread it apart with your fingers and make sure that it's not deep. Okay. And then there's a patent anal opening. We do not do rectal temps anymore. Okay. What we're going to guide ourselves by is that there's passage of meconium within the 24 hours. Just to mention meconium, meconium is formed, I always find this very interesting, formed from mucus, vernix, lanugo, that thin downy hair, hormones, and carbohydrates. So interesting. We'll see lanugo in just a minute here. Okay, so there's our anus and there's our spine assessment. And we're also assessing their extremities. Okay, that they're symmetrical, there's full range of motion. Their creases, if they're full-term babies, creases cover their entire foot. So their number of creases is going to tell us the maturity of this newborn. The more creases, the more full-term they are. The less creases, more preterm. Then syndactyle, okay, are these, we'll just go back here for a second. Syndactyle is fused, or what I knew I had it, okay. Fused or webbed digits, fused together, okay, this is syndactyle. Fused or webbed digits. And then polydactyl is extra digits, okay. So this little baby here has got this little extra digit, okay, going on. Then we have Ortolani's maneuver, okay. We have the Barlow, which is the knees moving forward, and then the Ortolani, which is abduction, okay, an audible clunk in abduction. And you can hear that when you're doing it. You can also feel it. That's for hip dislocation. The healthcare provider will do this before this baby goes home, okay, to discharge. Before they leave the hospital, they will get their head to toe, and they will also get their assessment for hip dysplasia, okay? And what we're listening in Ortolani's maneuver is the normal is that the head of the femur is in the acetabulum. That's the normal. So that's why when it's not, you hear this audible clunk in abduction, okay? And then the picture that I was going through before is that simian crease, okay? That's that single crease. These slides want to continue to move forward by themselves. The simian crease, okay, a single transverse crease across the palm of the hand. So a lot of times when this is happening, these are one of the assessments that we do. This happens when in Down syndrome. Okay, we have the simian crease. All of us will have normal palm creases. Okay, there's always a break in them, but that simian crease, as we call it, is common when the babies are Down syndrome. They have some form of chromosomal abnormality. And then we're looking at skin, which is very important. You want to make sure that their skin is soft, smooth, warm to touch. Now you have the list with you, and I'm going to move on to their pictures. So milia is small, pinhead size, white papules. These are caused by plugged sebaceous glands. They usually disappear on their own within a few weeks. Very common in the chin, the bridge of the nose, the forehead, and the cheeks. And we have lanugo. Well, we have vernix. This is a great picture of vernix. Exactly how I'm going to tell you. It's a moist cheese-like substance, just like that, just like you see it, okay? Because until 35 weeks, they're covered with this white, moist, cheese-like substance. So this baby is probably a 36-weeker, brand new 36-weeker, and that's why he still has so much. Closer to your 40 weeks, they don't have as much because until their 35 weeks are completely covered, and then of course, I call it like the baby oil, the natural baby oil, and then it starts to dry up, and then you really see that they're born and they barely have any vernix. Okay. Now lanugo, here it is. I knew this was coming. See all the fine downy hair, okay, in lanugo. It's fine downy hair along the back of their neck and their back. Okay, usually preterm. This is a little preterm, a little 35 weeker, 34 and a half, 34 weeker looks like. okay? More common in the preterm babies, okay? Again, as they go into closer to 40 weeks, you're not going to see this downy hair. They're going to see more mature, drier, dry, shriveled feeling skin of more of a full-term baby. And you have Mongolian spots. Okay, these are irregular, just like you see here. Irregular area of deep pigmentation. It's the hips, the sacral area, the gluteal region. Okay, how you see it here. And then erythema toxicum, it's a newborn rash. Okay, common in the first 24 to 48 hours. Sometimes it extends till about 7 days. Normal in the trunk, in the groin area, in the back, in the abdomen. Then, of course, you've got cyanosis before we get to port wine stains. And you have two other terms in your slide, cyanosis, which is the blue dusky appearance, and then jaundice, which we will talk about in high risk newborn, which is the yellow skin, very worrisome if it's yellow skin below the nipple line, and it's caused by too much bruising or maybe liver disease. And we will talk about that, so hang on to that thought. We will talk about jaundice and hyperbilirubinemia when we talk about high risk newborn. And last but not least, we have birthmarks. We have stork bite, okay, which gradually goes away within the first year. This is the neck, over the eyelid, the bridge of the nose, the occipital bone. And this is caused by dilation of the capillaries. And then you have the port wine stain, okay, nevus flammeus. Okay, caused by a capillary hemangioma. Okay, laser surgeries are now, they're doing them more and more, younger and younger. Was barely around 20 years ago, and they're doing wonders with laser surgery and port wine stains. It's usually in the face, in the limb, in the trunk. If they do the laser surgeries, they have to do multiple because there's laser beams, so they do multiple areas. And sometimes if it's close to the eyes, they give them a little bit of anesthesia. They do outpatient. They put them in that way. They can sedate them. They're not moving, and they can do their laser surgery. Okay. And how you assess, I lose my cursor, how you assess is when you touch the skin, it goes pale red. And then all of a sudden, when you take your finger off, it goes to a deep purple. So it blanches to with a minimal pressure. And then we've got meds, which we will do in skills lab, prophylactic medication administration and screening. We have your IM vitamin K. We have erythromycin ointment, okay, again, for the ophthalmia neonatorum, so that for gonorrhea and chlamydia, regardless if mom is positive or not, the baby is going to be protected with their erythromycin ointment, okay? Hepatitis B vaccine, all infants, regardless of the mom's hepatitis B status, and that's according to the CDC, the Center for Disease Control, and the AAP, the American Academy of Pediatrics. It is the first vaccine that can be given at birth, is hepatitis B. Okay, and vitamin K is obviously for clotting. Okay, so now baby's on their own, so we're going to give IV vitamin K. And then there's glucose screening. Okay, glucose screening, anything less than 40 is abnormal. Okay, diabetic moms, preterms, we have to check their glucose. Okay, babies that have been asphyxia, that have had D cells in utero, that have dropped their heart rates. Okay, anytime there's some fetal well-being that's been impaired. Okay, anytime that the baby has suffered respiratory difficulties, okay, in utero, and now the baby's born. Cold stress, now the baby feels cold, the baby's temperature is cold, the baby's not warming up. Sepsis, okay, any of those will interfere with glucose, and it will increase their glucose use. So these conditions increase metabolism and increase their glucose use. So you've got to do glucose screening. Okay. Again, diabetic moms, preterms, anytime that there's a baby has, suffered in utero, it's compensating in utero. When they're born, we've got to make sure that we do glucose screening on them. Okay. And then signs and symptoms of hypoglycemia, low glucose levels. Okay. They can get jittery, they can get hypothermia, and they can get apnea. Okay, so again, that's another sign of hypoglycemia in newborns. They're jittery, they're hypothermic, they're apneic. Glucose screening is PRN in the nursery, so if you suspect, you can go ahead and do a glucose screen on them. And then reflect an IM injection, okay, and we will practice in the lab. It's a vastus lateralis, so it's between femoral, okay, and their patella, and it's halfway, and it's vastus lateralis, so it's to the side. Okay, the vastus lateralis. This is for you. This is so you know the labs and the diagnostic tests that we do, routine testing, the blood glucose, a urinalysis, a bili, a CBC. Okay, and then newborn genetic screening is that inborn errors of metabolism we will talk about in high-risk newborn. And then the newborn hearing screen that every newborn gets before they're discharged. Okay. And then reflexes. You can look up these reflexes in your book. This is an indirect evaluation of the cranial nerves. And reflexes are done with their head to toe, their physical assessment before they're officially discharged, done within 48 hours after birth. Okay. There is feeding, which is rooting, and sucking is for feeding. Okay. Rooting is usually gone by 6 weeks. They turn their head towards a touch on the cheek. Okay. Sucking is usually decreased by about 6 months. Then we'll go back to the list. Then there's coughing, sneezing, and gagging, and those are all protective. Okay, that's protective. Now, tonic neck is what I had talked about. Remember when the baby was under the radiant warmer? Okay, tonic neck usually diminishes by 6 months. They're laying supine, they're turned their head to one side, and you can observe the extension of the arm and the leg on the side the head turns to. Okay, so it turns to the right, you see the extension of the arm, and then of course, you go to the other side and you see the same thing. One side relaxes, the other side contracts. Okay. And then you see the stepping, you see the Babinski, okay, the plantar grasp, the palmar grasp, the grasp of the finger usually decreases by 3 months. The plantar grasp usually decreases by 8 months. And the Babinski is actually all the fingers, all the toes flare up. So look at the reflexes. We did a little cheating there because I went through some of it with you, and you can go ahead and you can read on your book as well with the reflexes. And then you've got let's go back to the Moro. And then we've got the Moro startle reflex. And this is very important because the babies will extend their arms and they'll put their little arms in the shape of a C. Okay, and they startle. And this is really good because you want the babies back to sleep, just like the campaign many years ago. Back to sleep. You want them to sleep on their backs because you don't want them to get into this deep REM sleep, but then they have this sudden infant death syndrome. Okay, because they get so relaxed they forget to breathe. So you always want them in their back, and the first thing that they're going to do is if they hear anything, what are they going to do? They're going to startle. They're going to have this Moro reflex, and that's what you want. So that way they never fall into this deep sleep, at least for the first 3 months. I know there's wedges that put them on the side, but then it gets very dangerous because you don't want them to go ahead and flip over and then land on their bellies. So you really want to make sure that you put the babies back to sleep. Good part of education for the mom. Okay, and some key points we can go over before we conclude. And also you will get newborn assessment. I know you're turning those in when you do your clinicals. So you will practice again with the newborn assessments, turning them in, and your instructors going through it with you. We'll also go through it. I promise those of you that have been there know, and those of you that will go to Skills Lab, I'm letting you know that we are going through newborn assessment. We're showing the video and making sure that you practice your vitamin Ks, your Hep Bs, okay, your assessments on these newborns. So key points. Immediate nursing assessment includes ABGAR scoring and general evaluation. I'm sorry, this keeps on moving. General evaluation of physical status. Nursing care immediately after birth includes maintaining patent airway, preventing heat loss, and then, of course, stabilizing the infant, promoting parent-infant interaction. The newborn care of nursing care of the newborn may include diagnostic and therapeutic procedures. And then, of course, providing a protective environment is key responsibility of the nurse. So careful identification procedures, protection from abduction, support of physiologic functions, and measures to prevent infection. Thank you for listening to the newborn lecture. This concludes the newborn lecture.